Good morning. Welcome to the 2024 Curtis R. Holtzgang Visiting Scholar Lectureship. I'm Kayla Tabari, a clinical ethicist at Providence Center for Healthcare Ethics. We are broadcasting live at Providence St. Vincent Medical Center on Teams Live. You can earn continuing education credit for either attending this live session or for watching a recording of the session. And if you're looking for that recording, that can be found on the same link as today's event invite. My wonderful colleague Kevin Dirksen and I will be monitoring the question and answer section throughout the session. So please do feel free to submit questions as they come up, and we'll hold them to the end as time permits. The Visiting Scholar Lectureship is a program of Providence Center for Healthcare Ethics, named for Dr. Curtis R. Holtzgang, emeritus faculty at the Internal Medicine Residency at Providence St. Vincent Medical Center. During his tenure as Director of Critical Care Medicine, Dr. Holtzgang was an inspiration for generations of physicians in training, physicians and nurses working in critical care. He was instrumental in establishing the Providence Center for Healthcare Ethics back in the year 2000, and since that time, the center has become a recognized leader in advancing the importance of ethics in healthcare. I'd like to extend a big thank you to Dr. Curtis Holtzgang, who's here with us in the room today, and to all of his family and friends and loved ones who are joining us this morning. And now, it is my pleasure to introduce our 2024 Holtzgang Visiting Scholar, Dr. Kayhan Parsi. Dr. Parsi is a tenured professor in bioethics and health policy at the Neiswanger Institute for Bioethics at Loyola University, Chicago, where he's also the director of graduate programs in bioethics. He earned a law degree from the University of Houston and completed his doctorate in medical humanities from the University of Texas. Not only is Dr. Parsi a key educator and leader in bioethics, he's also a clinical ethics consultant for Loyola University Health System and serves on their clinical ethics committee. He has published in a variety of areas and has interests in clinical ethics, medical ethics education, professionalism and professional ethics, global health and justice, media and bioethics, the history of medicine and bioethics, and autism and neurodiversity. Dr. Parsi recently served as the elected president of our field's main professional organization, the American Society for Bioethics and Humanities, from 2021 to 2023. And in 2022, Dr. Parsi co-edited with Nanette Elster a book titled Transitioning to Adulthood with Autism: Ethical, Legal, and Social Issues. He is currently an associate editor for the American Journal of Bioethics. We are so honored to have Dr. Kayhan Parsi with us here this morning, and please join me in giving him a warm welcome. Thank you.
Well, thank you, Kayla, for that warm welcome. Thank you all for being here in person. Thank you all for being out there in the cyber world listening. I was talking to Kelsey this morning. I know this is the new normal where we have in-person speakers come and there's a handful of people in person and there's like 100 people online, although this is a great turnout. So thank you all for coming here on an 8 o'clock Tuesday morning to join us to talk about this issue. And again, thank you for Dr. Holtzgang for this lectureship series. I feel very honored to be here. I was looking at the list of speakers in the past. Really incredible group of people that have been here in the past to speak to you all. And thank you to the Providence Center for Ethics for inviting me. The title of my presentation this morning is Nowhere to Go: Ethical and Legal Issues in Complex Discharge Cases. I have nothing to disclose. And this is a topic that I've been interested in for some time, at least a dozen years or so. And I just wanted to share with you some of the headlines in the news that have emerged about this issue. This was something that was published a few years ago by NBC News. Healthcare laws leave hospitals overwhelmed by quote unquote permanent patients. That was the term used for some time. I just did a Google search this morning just to see if anything has come up in the last years. Really not much in the last few years about this, but that was the term used for some time, permanent patients. This was a headline in kevinmd.com. Who are the patients that stay in the hospital for a very long time? That was about 8 years ago. This is at UC Davis. How a hospital becomes a costly hotel for patients who can't leave. Patients in healthcare limbo have nowhere to go. This was in Connecticut. This undocumented immigrant has been stuck in the hospital for 6 months, and she's not alone. That was a few years ago during the pandemic. And I'll talk a little bit more about the specific challenges facing undocumented patients. This is my overview of my presentation this morning. So I just want to first define what is a hospital discharge. What does that mean? What does that entail? And then spend a little bit of time focusing more on this topic of a complex discharge, which is the focus of my presentation. And then explain the role of a complex case committee. This is a case committee that we developed at Loyola over several years to address these kinds of cases, provide a few case examples, and discuss specifically the challenges I mentioned that undocumented patients face, discuss relevant ethical and legal issues, and then identify and describe possible policy solutions. This was from the Healthcare Association of New York State. Our system of care is a design flaw. It is primarily designed for people with a clear path, for those who do not have complex care needs upon discharge. And I was reading a piece that was published recently that talked about leaving AMA. So the idea of leaving AMA is something that's well established, it's been documented, but something that they haven't seen is staying AMA, people that are staying against medical advice in a hospital setting. And so that's really the new world that we're dealing with when we're talking about these kinds of patients. Being stuck in a hospital is not fun. You all work in healthcare, but for your patients and their families, this is a weird place. Right? I mean, you come here as an inpatient patient, and your sleep is disrupted. The food is probably not that great. You don't socialize as you normally would. And so in this piece that was published a few years ago, they recommend that there are more purposeful collaborative efforts between professionals, nurses, allied health professionals to create an environment that closely mimics life outside of the hospital. I don't know if that's happening, but I think that's a worthy goal. What is a discharge? So this is a phenomenon that happens routinely, and it's really a process, so it's not an endpoint, but rather one of multiple transitions within the patient's care journey. And it's something that for years really didn't garner a lot of interest among ethicists. And I would say in the last 10 or so years, you're seeing a small but growing literature on this topic. And as I mentioned, this is truly a process, not an event. In bioethics, we often say that informed consent is a process, not an event. And I think the same applies to the transition process, to discharge process. It's a process, not an event. As with everything in healthcare, CMS has a big role in regulating how this process unfolds. So CMS has a discharge planning rule. It states that this process must identify at-risk patients. Hospitals must provide a timely discharge planning evaluation of patients. So this is something that should happen for all patients. This one, I think, is particularly relevant to ethicists and to bioethics in that we're trying to align this information with the patient's treatment goals and preferences, however that may play out. And also, we want to preserve freedom of choice in their caregivers and selecting post-acute services and providers where required. So again, we're trying to preserve patient autonomy as much as possible, as much as feasible. What is a complex discharge? So we've learned a little bit about what a regular discharge is, but what is a complex discharge? So this is, and it sounds kind of tautological, a complex discharge deals with complex problems, but that's what it is. And issues that result in the need for extended and labor-intensive discharge planning. So these are not routine discharges from the hospital. They entail a great deal of complexities because of the patient's level of healthcare needs, post-acute care needs, may deal with lack of insurance coverage, so a variety of things are at play. Why do complex discharges occur? For one, a safe discharge is not possible. So that is probably the most important requirement, that a discharge has to be safe. That may not be possible for a variety of reasons. A person may not have a safe place to be transitioned to. There may be a lot of reasons why a safe discharge isn't possible. The patient lacks insurance for placement in an appropriate facility on the continuum of care. This is something that we see routinely. I think this is what triggered a great deal of interest in this topic 10 or 12 years ago is that we were seeing patients who lacked insurance, lacked either private insurance or some kind of public assistance to support their transition to some kind of long-term care facility. Another reason is that the patient or their surrogate refuses a safe discharge plan. So that kind of goes back to the staying AMA idea, that the patient is staying AMA against medical advice. There's no need for the patient to be in an acute care setting, in a hospital setting, and for whatever reason, the patient and or their surrogate refuses a safe discharge plan. Another reason is that there may be a lack of disability benefits. So for those patients that are disabled or need disability services, there may be no benefits available for that patient. And this is something I'll talk about a little bit more tomorrow when we talk about autistic individuals transitioning from adolescence into young adulthood. We basically move from a model of entitlement to services, whether we're talking about educational services or healthcare services, to a model of eligibility. And making yourself eligible for services can be incredibly time consuming. It can require a lot of coordination from the individual, from their caregivers, from parents, from guardians. So the lack of disability benefits can be a real huge barrier. Another reason, and this is the one that I'll focus on this morning, is that when a patient is undocumented, they will not be eligible for public assistance, such as Medicaid, which could potentially cover placement in a long-term care facility. And so when we started witnessing this phenomenon about a dozen years ago at Loyola, this was kind of the prototypical case. Undocumented patient lacks insurance, and so it's really challenging to transition that person into some kind of long-term care facility. In response, what we did was we developed this complex case committee. And this started maybe 8 or 10 years ago at Loyola. It was an ad hoc committee at first. We would just gather together all the relevant players, stakeholders. It was chaired by one of our palliative care physicians and people from social work, case managers, nursing, ethics, risk would all come together, and they would try to deal with the situation as it arose. So it was very, again, kind of ad hoc, not a really systematic or routine process at all. But then about 7, 8 years ago, we decided that it was important to make this a standing committee, that it shouldn't be just an ad hoc committee that we kind of just throw together on the fly, but that it's a standing committee of the hospital chaired by one of my colleagues in palliative care. And so now it's a standing committee. It meets every week. It's a multidisciplinary committee, as I mentioned. So in some ways it mirrors an ethics committee meeting chaired by a case manager and by a physician. And then whoever is the ethics consultant on call will attend. And these take place every Wednesday. And so we're there to provide support, to act as a sounding board, to raise questions. And these cases often will address difficult to discharge patients. As I mentioned, this is a very, kind of multi-pronged issue. You have a lot of different players, a lot of different stakeholders involved. You have, of course, the patient at the center, but then you have family members who are involved in the care of the patient, a variety of different healthcare professionals involved. And the healthcare professionals involved, it may vary from institution to institution. So at Loyola, we're a level 1 trauma center, several hundred beds. I have a colleague who now works at Cornell Weill in New York, but she used to be the ethics director for the Donnelly Center for the Shirley Ryan Ability Lab, formerly the Rehabilitation Institute of Chicago, also face similar issues, but there it's primarily rehab professionals who are dealing with this issue. Administration, of course, long-term care facilities that are trying to work with us in placement, the community, local community primarily, the larger society, and of course, government. So all these different players and stakeholders are involved in trying to address this issue. So as you can see from this this graphic, hospitals may be required to work with more than 20 entities at the state, regional, and local level to discharge a single complex case. So a lot of resources, a lot of different people, a lot of different entities. So you see here everything from citizenship and immigration services to agencies for individuals with intellectual and developmental disabilities, social services, hospitals, community organizations, residential facilities, schools. So a variety of different stakeholders are involved in this issue. So just a couple of case examples to share with you. Now, these were publicized in the media in the Chicago area. This first one dealt with this young man, Mr. Jimenez. This was back about 12 or 13 years ago. The headline says, undocumented worker who became quadriplegic is moved to Mexico against his will. So Mr. Jimenez was a roofer. He fell off a roof. He had a catastrophic injury, resulted in quadriplegia. He was being treated by a hospital within the Advocate system in Chicago, and he was repatriated back to his country of origin, which is Mexico. Now, this was done without his consent. So this then generated a lot of questions about what is ethically and legally appropriate for a hospital to do with regards to repatriation. And this generated a lot of discussion in the media. Advocate then developed a more formal process in addressing these kinds of patients. But this was one of the early cases that occurred in the Chicago region. This is another case that happened roughly concurrently with the Jimenez case. This was a 57-year-old woman who had a massive stroke. She was stabilized, treated for a stroke, no longer needed the care in an acute care hospital. The clinical team prepared her discharge plan. Similar to Mr. Jimenez, this patient was undocumented, had no private insurance coverage. Because she lacks a lawful immigration status, she is not eligible for public assistance such as Medicaid. So again, this is an ongoing challenge. So without that kind of coverage, long-term care facilities will not admit her. Her son wasn't able to care for her at home. Despite having no acute care needs, she ends up staying in the hospital for over 2 years. So she became one of these kind of classic permanent patients. Eventually, with the patient's consent, she's repatriated to her home country of Poland. The hospital decides to review their discharge policies in light of the growing number of undocumented patients. So this was concurrent, as I mentioned, with the Jimenez case. This resulted in Ms. Latasowicz being repatriated back to her country of origin, which is Poland. This was in the Adventist system. This also garnered some press coverage in the local media. She spent well over 2 years there. This was different ethically, legally, because she did provide consent for repatriation. And so here she's, looking tearful at O'Hare, but she felt like she was being well cared for by the professionals at Adventist. But again, it was a critical difference from the Jimenez case that occurred at Advocate. So I've mentioned that undocumented patients pose special challenges because of the nature of our healthcare system and how we insure people, how we cover people. Medicaid only provides for coverage of emergency treatment, not long-term care of the undocumented. The Medicare Prescription Drug Improvement and Modernization Act of 2003 provides some modest reimbursements, but it's not very generous, so not a lot of help there. And of course, layered on top of the undocumented are the unrepresented. And again, this is another serious challenge for hospitals and healthcare systems in the US. This has been written about by a variety of people. This is by Dave Ozar, one of my former Loyola colleagues in the AMA Journal of Ethics, where he says unrepresented patients are hospitals who lack decision-making capacity but have no advance directive and no one to serve as a legally authorized surrogate. So sometimes these are distinct categories, the undocumented, the unrepresented. Sometimes they overlap as in a Venn diagram. And so that just doubles or triples the challenge with regards to how to best serve the needs of these patients. Well, what about EMTALA, the Emergency Medical Treatment and Active Labor Act of 1986? So this has been on the books now for close to 40 years. This act was created to prevent patient dumping. However, it doesn't extend to subacute care facilities or the long-term care centers. So it really just applies to acute level hospitals and emergency rooms. And there really is no financial or legal obligation for facilities to accept patients with no insurance or only pending Medicaid coverage. So there really isn't any strong incentive there. So when we're dealing with these kinds of cases and trying to discharge the undocumented patient, we have to ask ourselves a number of questions. So these are questions that we're trying to answer when we're working together as a complex case committee. Does the patient have insurance? Now, mostly no, but occasionally yes. So that's something we have to determine. Is the patient in the country legally with proof? Do they have a green card? Is there a visa, some kind of asylum request? Can the patient qualify for Medicaid in the country legally for 5 years and anticipated to be disabled for a minimum of 1 year? So that occurs infrequently, but it does happen. Are the patient's family members also undocumented? So those are some of the questions that we want to ask ourselves as committee members. Further questions that we ask ourselves are, does the patient have family or friends in the country? So sometimes the challenge is just trying to train family members to care for the patient at home. So if you remember the case of Ms. Lutasowicz, the challenge there was that she had a stroke, unable to care for herself, and her son was unable to care for her. Could that case have played out differently if he was trained differently, if he had the ability to care for her at home? Will the patient require further medication or rehabilitation once no longer acutely ill? And is the patient able to make decisions on his or her own behalf? So again, it goes back to that question of whether the patient has capacity and whether that patient has some kind of surrogate making decisions. What's available in the community? So again, that first question relates to what I just said. Can family members be trained to carry out some of these services, typically carried out by home health care? Is the hospital willing to lend some equipment for the patient and family to take home while the patient rehabilitates? That's something that we try to work out. Are there faith-based or cultural specific nonprofit services that assist financially through volunteer caregivers, transportation, and translators? So that's also something we try to work with in our local community in Maywood. Maywood is right outside of the city of Chicago, and so we work with various different faith groups, charity groups, in trying to help these individuals. What do hospitals do? So there's different options on the table. We can keep in rehab. So keep in rehab the patient until they can function independently at home, but that may be weeks, months, years, as we saw. Repatriate undocumented patients to their country of origin, which again happened in both of those cases that I mentioned, but that is fraught with some legal and ethical challenges. And then another consideration that we've done is contract with nursing homes and just pay for nursing home care outright. And what we've learned is that paying for nursing home care can be a lot less expensive than housing patients in a hospital for weeks, months, and years. How have hospitals been handling these cases? Well, so some patients just may never be able to function independently at home. And that's a fact. The other challenge is that a country of origin may not accept the patient. There may not be a hospital facility to take the patient. So when we meet as a committee, we're often trying to determine, is there a facility or hospital or long-term care facility that will be willing to take this patient if they are repatriated back to their country of origin? The patient may need permanent nursing care. Is the hospital responsible for the cost for the remainder of the patient's life? So this is something that we ask ourselves. Now, it hasn't happened. We haven't housed patients for the entirety of their lives. But when we're getting into years, that is a thought that crosses members of the committee's minds. Relevant ethical issues. So of course, this relates to a number of relevant ethical issues. These are, of course, the venerable four principles in bioethics: beneficence, non-maleficence, autonomy, justice. And of course, beneficence and non-maleficence, I think, are pretty straightforward. We want to do good for the patient and we want to avoid harm. We want to respect the patient's wishes. The last one, justice, is the one where I think comes into play here, ensuring that patients are treated equitably and that scarce resources are distributed fairly. When we're dealing with patients who are staying AMA, how do we how do we incorporate justice in our thinking? In clinical ethics, we may talk about justice, we may write about justice. We are loath to talk about justice with patients and their family members. We don't ever want to say, well, your patient has fulfilled, we fulfilled your obligation to your loved one, and now it's time to go. And so we try to be aware of this issue, but it's, I think, a very challenging issue to bring up with patients and their families. So are there different models out there to help us kind of resolve this issue? So in addition to the 4 principles, there's organizational ethics, which has been around for some time. Here, we're looking at systemic issues. We're looking at stakeholder responsibilities, as opposed to looking at the 4 principles, which are very helpful in trying to resolve these issues. Are there broader systemic issues at play that we can try to address? Codes of ethics are very clear about patients in these situations. So if you look at this code opinion from the AMA code, it says the discharge plan should be developed without regard to socioeconomic status, immigration status, or other clinically irrelevant considerations. So the code is very clear that when we're coming up with responses, with solutions to these problems, that we're not looking at socioeconomic status or immigration status. And so in determining when a physician or a patient is ready for discharge, we're looking at basically, is the patient medically stable? Are they ready for discharge? And that each plan should consider that patient's particular needs and preferences. So again, the AMA Code of Medical Ethics is very clear. No discrimination allowed based on immigration status or socioeconomic status, and that we have to be sensitive and attentive to each patient's particular needs and preferences. Other professions' code of ethics also very, very clear. So if you look at social work, section 4.02 prescribes social workers from condoning or facilitating any form of discrimination on the basis of immigration status. Again, very clear. Section 6.04 encourages social workers to promote policies that safeguard the rights of and confirm equity and social justice for all people. Again, very clear. So we want to be equitable, we want to be fair, we want to be just in the way we deliver care. As I mentioned, that repatriation is an option on the table that we consider, but it is fraught. It can be a violation of human rights. So the notion of repatriating someone against their will is a activity that's really reserved to the federal government. Everyone has due process rights, the right to life, liberty, and personal security, the right to preservation of health and well-being. So repatriation is something that has to be done very carefully and very sensitively. And my colleague Mark Krzyzewski, who was a former speaker here years ago, he's written about this issue and about a communitarian approach that that if you look at the codes of ethics of the AMA or the social work, the ANA, that we really want to treat everyone fairly, and that we want to make sure that that our immigrant neighbors are being treated fairly as well, and that they're members of the community because they're living within and contributing to the community. So I've talked a bit about the 4 principles. This scholar, Friedrich, wrote an interesting piece in the last few years about complex discharges, and she wants us to look beyond the principles. And so she's talking about how this idea of acknowledged dependence is really what we should be looking at. And so it would enable providers to embrace their obligations and responsibilities as they work through these difficult situations. But she says that this idea of acknowledged dependence also has a claim on patients and families. They're not entitled to unfettered autonomy simply because they're dependent. We're all dependent. And thus the patient's request for resources is not beyond scrutiny because patients are not being asked to consider limiting anything that one would not theoretically consider limiting for oneself and one's community. The virtues of acknowledged dependence allow justice to play a more prominent role in discharge issues. Now, I think that's easier said than done. I think, again, it can be very challenging to bring up issues of justice in clinical ethics consultations. But what she says here is that issues of justice or resource allocation are often noted, but not often satisfactorily addressed, which I agree. since it's difficult to fulfill all the competing moral claims to justice by members of a given community. However, when exercising the virtues of acknowledged dependence, a patient or family's request can be considered within the context of what is possible, what's feasible, and what is reasonable in the medical and moral community. And I think these issues can be addressed in our complex case committee. So I think we can adequately address these concerns about justice, about this idea of the virtue of acknowledged dependence. All that can be addressed, I think, within our complex case committee. There's some policy considerations that we have to be mindful of. Can repatriation be done ethically? No, I think it can be done ethically. And again, Mark Krzyzewski has written about this, and I've addressed this in a couple of articles as well. Some of the questions to ask ourselves is it in the patient's best interest? Can the hospital exercise due diligence regarding the medical support available? And can the patient or their surrogate give fully informed consent? So I think the third one is really, really critical. It goes back to the case of Mr. Jimenez, who did not give his consent, wasn't really clear what he was aware of with regards to his repatriation process. Without informed consent, however, it's really a non-starter. It's fraught with ethical and legal challenges. As I mentioned also, the AMA's CJIA report here stated that when you're doing this, forcing an immigrant to leave the U.S. is really the prerogative of the federal government. This is not something that hospitals should be in the business of without a patient's consent. With the patient's consent, it can be done, again, but carefully and thoughtfully. And this was, again, been written about in a variety of different venues. This was a New England Journal of Medicine piece that occurred some years ago. I think this was kind of the crest of the wave of repatriation. I think now it's become more common. I think a lot of hospitals engage in this, but they do it in a more ethically thoughtful manner. So there's some potential policy solutions that we can consider that are on the table. So we can require long-term care facilities to accept undocumented patients. That is probably not going to happen in the current political environment, but that is something that we could consider. Extend Medicaid eligibility to the undocumented. Again, this is another challenge. Medicaid, as we all know, is starving for resources. And so extending eligibility is another challenge. Permitting ethical repatriation of undocumented patients to their country of origin. This does happen, and like I said, it happens at our institution at Loyola. Other institutions do it, again, in an ethically sound way, but it has to be done with the patient's consent and with all of those other criteria that I've mentioned earlier, having a safe place to discharge and a facility willing to take the patient. Allowing undocumented to participate in insurance exchanges, again, that's something that's not permitted now. So there's a variety of different potential policy solutions here. So the UC Davis health system, which I referenced earlier in my presentation, they developed a number of factors that they think could be developed to improve this process. So reduce the time it takes to get a court-appointed conservator, and establish a special case waiver to access benefits for adults with IDD, improve and streamline access to assisted living support services, extend wraparound services opportunities for individuals with extreme disabilities, build more bed capacity in the Sacramento region. So this is more specifically tailored to patients with IDD, with some kind of disability, who may lack decision-making capacity, who need perhaps a conservator or guardian to make decisions on their behalf. So again, but there's a variety of potential solutions there on the table, at least in that health system. So going back to the Healthcare Association of New York State, this delay problem, again, is multi-pronged, and you see all these different players. I think executive leadership has to play a big role, as indicated in this infographic, along with all the other different players, palliative care, physicians and nursing, legal, risk, case management, behavioral health, finance, ethics. As I mentioned, that this is an area that has not garnered a great deal of attention among ethicists. There is a small but growing literature on this topic. I co-wrote a piece that appeared in HEC Forum that appeared about a year ago about complex discharge cases, but again, it's part of a small literature, not a huge literature, interestingly enough, even though I think ethicists are getting more and more involved in this issue. So this was a piece written by one of my colleagues at UIC, Christy Kirshner. Christy is a physician. She does work in disability health. She's done a lot of great work in trying to expand care for people with disabilities. And I think what she says here, I think, is really on target. So she said, you know, we undoubtedly need structural reform, better long-term care options, sensible solutions, reasonable choices, and more individualized and flexible decision-making. I will close with a quote from one of our authors about, first and foremost, attending to the voices of our patients. So this was in Narrative Inquiry in Bioethics, published a few years ago. Although our healthcare system needs a serious overhaul, input from patients on an individual basis is the only ethical path for recovery to occur effectively. Just as individuals with disabilities are given an individual education plan or IEP for the educational journey, why is this not mandatory for medical situations? Patients must have their voices heard. And so this is something that I'm seeing more and more with regards to the discharge planning process, that just like with patients with IDD or individuals with IDD have often IEP for their education plan, and that's often for young people, people that are children and adolescents. It gives everyone involved an idea of what to expect with their educational journey. What are the goals? What are the metrics we're going to use for that for success? What are the educational outcomes that we're looking for? So similar to having an IEP in education, perhaps we need to do something similar for patients. And this could be really for any patient. It doesn't have to be, I think, for patients with intellectual and developmental disabilities. It can be for any patient, especially patients who may potentially have challenges with regards to discharge. And as I outlined in this presentation, this can occur for a variety of reasons. It can occur because patients lack decision-making capacity, they may lack legal status, they may have an IDD, and so there may be a variety of reasons why patients could benefit from this kind of plan. So to conclude, you know, these discharge decisions involve a multidisciplinary approach, as I've mentioned. So this really is a team effort. It really takes a variety of parties, a variety of stakeholders to come together to address these issues when we're dealing with patients who need a discharge. As I mentioned, on the one hand, this is an incredibly routine process for millions of people. People get routinely discharged from hospitals every day in this country, from all sorts of hospitals and facilities. And in general, it is not fraught with a lot of legal and ethical peril. However, occasionally they do. And so we really do need to embrace and encompass a variety of different stakeholders. We need, I think, to think more imaginatively and creatively about what kinds of ethical approaches do we need to help us think through these challenges beyond the four principles: autonomy, beneficence, non-maleficence, justice. I think we need to take more seriously organizational ethics that looks at stakeholders and their role and what are their interests that they're trying to advance. And cases involve issues related to decision-making capacity, disability benefits, legal status, and so forth. So a variety of different kinds of topics emerge as to why there may be a difficult discharge or complex discharge. And again, depending on where you practice, where you work, these benefits may be more generous or less generous. And then I also mentioned the creation of this standing complex case committee at our institution, which we found to be extraordinarily helpful in thinking about working through these cases, trying to meet the needs of our patients, the clinicians caring for them, and being attentive to this issue in a way that is systematic, that's consistent, and that is thoughtful. And so we've been doing this for several years. I gave a version of this talk about a year ago at Corewell Health in Detroit, and they made the decision to revive their complex case committee because I thought it was a really important way to address these issues. And I think for us, at least at Loyola, it has been a very, very helpful way to address these challenging kinds of cases. And with that, I will stop and take any questions. Thank you.
Thank you, Dr. Parsi. Really appreciate you walking through both the issue at a more general theoretical level, as well as getting into the examples around the particularities of discharging patients who are undocumented and still need access either to acute care or aspects of subacute care. I'm interested from your last bullet point, this notion around creating a complex care committee. And one interesting thing about this milieu at Providence, and you're speaking across to kind of an integrated healthcare system, not just here at St. Vincent, but across the river at Providence, Portland, some of our facilities ranging in size anywhere between 500 licensed beds to smaller facilities, 75 licensed bed at Milwaukee, not far from us, and critical access hospitals in a short drive. Is what would a kind of committee like this look like at different sites in our system or at a regional level or other places? And one of the things I'm interested in is you sort of said it kind of feels like an ethics committee at times. And at times when we've been a part of this work and these committees have functioned, I can kind of sense some similarities in terms of the interdisciplinary, multidisciplinary feel. But one of the absences that I've noted is the feedback of patients in the process from, say, a lived experience of being a patient with complex healthcare needs. And one of the hallmarks of the bioethical establishment in healthcare is to have a community voice on an ethics committee. And I'm interested in your thoughts about if we were to channel a principle like nothing about us without us, how would we derive more participatory feedback from the lived experience of patients with complex health needs or the community perspective on it doesn't quite serve me well if I need to come to the hospital and you're full stuck with permanent patient. So interested in your thoughts on that.
I'm actually going to build on that question. Someone in the chat says, I'm curious if patients or family members ever attend your complex discharge committee and how you decide if when to do that. And that's a bedside caregivers. They have the same question, Kevin.
Yeah, thank you for that question. I think that's an important question. It's something that we try to grapple with in ethics committees in general. So I see a lot of discussion about the role of community members in ethics committees and having a voice. Part of the challenge is, what does that mean? You know, one person is not necessarily representative of all patients, right? So how do you go about selecting that person to be that voice? So I think that's a separate set of challenges with regards to clinical ethics committees. With regards to our committee, you know, we don't typically have patients come to our complex case committee meetings. However, we do have members of the committee that engage directly with the patient and their family in trying to resolve whatever issue it is. And so in that sense, the patient is involved in their own discharge planning process. But we don't have patients and their family members come to the meeting. The meeting itself, I think, is in many ways, you know, as an ethicist, I feel of kind of like an insider outsider, you know, because I mean, it's kind of like for those of you who are West Wing fans and Aaron Sorkin, like people are talking super rapidly and everyone's throwing around a lot of jargon. And I'm just trying to get a question in, like, okay, well, what about the patient's decision-making capacity? Like, you know, are we respecting the patient's autonomy? Those kinds of questions. But so I think it's a really valid point, and I'll bring it up to our chair as to whether we should bring patients or their surrogates to come to the meeting. I mean, the challenge is that, you know, we're going through a series of cases, and so we have to be sensitive to obviously privacy and confidentiality. But what happens with each case is that a social worker or case manager who's directly involved in the case will come talk about the case, and they'll talk about the patient's involvement, surrogate's involvement, the family's involvement. So in that sense, it's indirect, but not direct. And so I think it's a really interesting point as to whether we should have more direct involvement of the patient and or their surrogate and or their family members. Yes.
Several cases that you think about often and stand out in your mind. Do you have a particularly difficult one that had a very good, successful outcome, and what did it take to get there?
Yeah, so I'm thinking about the cases that are similar to the cases that I talked about here, where a patient lacks legal status, they don't have insurance, they may not be Medicaid eligible in Illinois. But I think in those cases where we've seen success is where family members can involve themselves in the care of the patient. We can train those patients, family members, in delivering services directly to their loved one. And so I think in that sense, that is like a modest success. We've also, as I mentioned, contracting with nursing homes, like we've done that. We will contract directly with nursing homes, pay for care, and we feel in that sense that the patient is getting the level of care that's appropriate for their level of need. They don't have to live in a hospital forever. That's not good for them. That's not good for anyone. And it's much more cost effective. So I think that for us meets the criteria that we're looking for, that we want a safe discharge. We want it to be ethically and legally appropriate. We want the patient's care needs to be met. And it's more of a long-term solution. So those are the kinds of cases that I think where we feel like we've made a difference and we can try to resolve some of these challenges.
Thanks for your talk. We talk about being an integrated healthcare system, but Providence, like most healthcare systems across the country, has one pretty glaring gap in the services that we provide, in that we don't offer any post-acute or long-term care services. In this country, most of those facilities are owned by private equity interests. So I'm wondering if you can speak a little bit to, do you see an ethical obligation for healthcare systems, or are there ethical complications that come from these interests being owned by private equity and having to come up with some of the complex arrangements like you talk about, such as contracting with these facilities?
Mm-hmm. Yeah, again, that's a great point, and it relates to that one slide that I mentioned earlier about how these facilities have no legal, financial, or really ethical obligation to admit these patients into their facilities. Part of the challenge is just the way our healthcare system has developed over the last several decades, years, is that hospitals, health systems were developed oftentimes with a certain mission in mind, right? I mean, Catholic Health has this very, very specific mission that's very deeply rooted in ethics. Secular systems also have some kind of often ethics commitment. There's certain legal requirements, as I mentioned, EMTALA. None of that exists with these private facilities. So I think it would need a tremendous amount of pressure on policymakers, on political officials to say, look, we look at patients as if they're just, their needs are somehow evaporate when they leave the hospital, and they magically get better and everything is good in the world. And that's not how patients need consistent care. And that's as critical. That transition from the hospital to long-term care facility, nursing home, wherever, is as critical as the treatment that they get. And so I think we would hope that people would do the right thing, but without some kind of legal pressure, I think people often will not do the right thing. And they just lack that history of mission that I think you see in hospitals and health systems. And then with the introduction of, as you mentioned, private equity, that just adds another layer that I think is deeply problematic.
You've focused a lot on your talk in the particular problem of hospital discharges, particularly for patients who are undocumented. Yeah. And but I wonder if what happens in Europe, in many countries in Europe, for example, where there is a similar burden of care for similar patients, but there isn't this idiosyncratic funding problem for long-term care. It's not that there isn't the problem, it's just that the fulcrum of that problem doesn't happen at hospital discharge. Is this just an American problem?
A great question. I don't know what the situation is. My sense would be because they have universal health care, it is more seamless and not as fragmented as our system is. I mean, going back to the previous question, that we kind of pick and choose what we think is deserving of coverage, right? So we have this idea in the United States of the deserving poor. And so certain people get certain services and certain kinds of resources, and others don't. I think because Europe, again, has this commitment to universal health care, my sense would be that this would be a more seamless process with regards to transitioning from acute care to other kinds of facilities, and probably not as contentious as it is here in the US. I don't know. I'll look into it, but I think it's a great question. But I think, again, because our systems are so different and the way we finance healthcare is so different, that I think that would be the case.
So I love how the Q&A to date has been engagement by our physicians, but I also know from a multidisciplinary standpoint, we have nurses and I see some social workers in the room from care management. Could I tempt the honing microphone?
I'm one of the social workers here in care management, and I had to question myself and look it up. But Oregon Medicaid did make a program July 2023 called Healthier Oregon, and undocumented individuals are covered with full Medicaid and long-term services as long as they meet that financial criteria. So it's been a game changer, and I can see that each state is different with their allocation of Medicaid benefits. My stepsister is a social worker in another state, and she's blown away by what Oregon can provide. So I don't know if everyone in the room is.
Yeah,
aware of that.
for Oregon. Thank you for that. But I think what you just mentioned, again, it shows the fragmented nature of our healthcare system, where some states are going to be more generous. It kind of reflects the values of the state. I'm not surprised Oregon has done that. New York and California also have similar Medicaid programs that will provide coverage for this population. And so again, it's just our system is so fragmented. What I tell my students, I teach a whole course on justice and healthcare. I say we don't have a healthcare system in this country, we have healthcare systems. And it's very pluralistic, it's very diverse, depending upon who you are, whether if you're over 65, whether you're indigent, whether you're a veteran, whether you're Native American. It plays out very, very differently. But thank you for sharing that about Oregon.
And Bern, not to take any credit at Providence or ethics or aspects of some of the cases we struggled through, but there was principally around issues of folks who were trying to access dialysis in our emergency rooms that were undocumented, as well as folks with questions about repatriation that really became an advocacy interest for us before the pandemic. And there was a lot of concerted effort to raise that in the halls of our state chambers down in Salem. And that was really the catalyst, is to see these cases aren't working from a financial reimbursement perspective. So to provide that level of resource on the front end, including things like preventative care, would be a much better way of being able to ameliorate some of the stopgap dilemmas that we get into down the road. So I think as a healthcare system, we can say by surfacing those cases and examples, that was in part why we had a funding mechanism change here locally. Anything from the chat, Kayla?
Questions in the chat, and it's tough to pick, but I'll start with this one. The systemic approach that you're advocating for sounds like something that needs to be addressed on the federal level with an increased role for public health departments rather than having each healthcare organization try to reinvent the wheel. Is the movement by the organizations you're involved with to lobby for that? What does that involvement look like?
Yeah, I think, again, that varies from state to state. Obviously, here in Oregon, there was a concerted effort to make these changes happen. And I think some states, as I mentioned, New York and California have well-established expanded Medicaid coverage. I think part of the challenge is that as ethicists, so I'm just speaking as my role as an ethicist, that we tend to focus more on what's happening downstream and what's happening at the bedside, what's happening in each individual hospital or facility, and we ignore, or at least we don't necessarily have the skill set or the time or the bandwidth to deal with these issues at either the state level, as was just mentioned, or certainly at the federal level, right? So last year at our professional society meeting in Baltimore, the American Society of Bioethics and Humanities, we had a set of speakers that talked about the role of bioethics at the policy level and what can we do to engage with legislators at the state level and with members of Congress. Actually, a lot of things happen at the state level, and we tend to ignore that, I think, as healthcare professionals, as ethicists, just as citizens. That the things that profoundly affect our lives happen at the state level. I think the challenge of the federal approach, as the attendee asked, is that just because of the current state of divisiveness in this country, it's very hard to get anything done. And so, again, something else I tell my students is that the U.S. is one of incremental healthcare reform. It's not one of radical healthcare reform. But we can see changes happen at the state level. And I would encourage folks who are really interested in this topic or this set of topics that I think that's where the action is. And I think I've heard just a couple of really good examples about that.
So maybe the last question I'll feature here involves something that, Kayhan, we did not specifically ask you to address in this lectureship, but is something that we are currently seeing across the continuum of care and represents probably one of the most difficult edges of, I think, this topic. And I'll just read the comment in full to give you the flavor. Much of our talk around these issues presume that the patient and family are capable of having a normal conversation. Many of the cases we experience are with persons, families who are dispositionally incapable of shared decision-making. They don't trust, they escalate to violence, they just are not able to enter into reasonable conversation. Is there a way to deal with such cases? And the particular aspect around the sort of disruption, the violence, maybe you can at least share some preliminary thoughts as we continue to tackle this within our healthcare systems.
This has become obviously a much more pressing concern over the last few years. With COVID behind us, I mean, there's been a huge spike, of course, in violence and aggression. This is just something I've noticed just on a personal level. Every time I go into a health system, there is signage everywhere about certain norms that you have to observe, that physical aggression, verbal threats will not be tolerated. I didn't see that 5 years ago. Now I see it. I don't know if I've seen it here yet, but I've seen it at every health system that I've visited over the last few years. So it's a real thing. I think that this issue of physical violence, again, our speaker a couple of weeks ago at our ASPH meeting was an expert on healthcare worker violence. He was a big advocate for training our professionals on de-escalation skills and trying to engage patients with a sense of empathy. Now, I know that can be very challenging, and I know there has been erosion of trust from many patients with the aftermath of the pandemic. Trying to restore that trust, I think, is something that has to happen, though, and it can happen. It can certainly happen at a systemic level, but I think it happens with every exchange, every encounter, every visit. But I think training our colleagues with the requisite skills to de-escalate issues. I mean, there are certainly some patients, some family members who are just inherently distrustful of the healthcare system. And so I think that's where you want to have, again, this kind of multidisciplinary, multi-pronged approach in trying to restore that trust. And some of that mistrust, a lot of that mistrust is deserved. But I think a sense of good faith hopefully will emerge from both the caregivers and from patients and their families. But this idea of, like, the word that I stuck on was dispositionally unable to deal and to talk rationally. And I think my hope is that that's not an overarching concern, that maybe it's episodic, that maybe people are episodically distrustful, but that building that relationship will create greater trust. There was a whole Hastings Center report devoted to trust in the healthcare setting, how to restore that trust. I think trust was badly damaged during the pandemic. And I think it's something that can be done hopefully at a systemic level, at a societal level, but also at a much more individual and intimate level.
I like ending on a word of hope as we continue to try to become trustworthy. Thank you, Dr. Parsi.